So today we'll cover an important part of gynecology, that is infertility. So what is infertility? Anybody? How we define infertility? According to WHO, infertility is defined as inability to conceive after 1 year of regular unprotected intercourse. Means when the couple is trying for 1 year and not able to achieve conception, then we started our workup for infertility. What is primary infertility? When there is no history of conception, either it is abortion, preterm life, nothing. So there is no history of pregnancy in the past. And secondary infertility, when patient had history of conception, whether it is abortion, preterm delivery, live or stillbirth. Means there is history of one pregnancy prior to first row. So according to WHO 2023, two of you come here, 1 and 2. First two, please come here. So in 2023, WHO gave the incidence of infertility as 1 in 6 couple in reproductive age group. Previously it was 1 in 8, now it is, the incidence is 1 in 6 couple. So roughly 20% of married reproductive age group couple are facing the problem of infertility. When we start investigating the couple, routinely after 1 year, but in some conditions like if the age is more than 35 years of the female especially, then we start after 6 months, and if it is more than 40 years or if there is some known cause of infertility like some genetic disorder or azoospermia, in those cases we start our workup immediately. So roughly 1/3 belongs to male infertility, 1/3 to female, and 1/3 combined. So 40 to 50% are female factor, 30 to 40% male factor, and 10% around unexplained infertility. The important causes of female infertility are, so roughly there are 2 things, or rather 3 things. Number 1, ovulation, transport of gametes and embryos, that is tubal function, and third is implantation in the uterine cavity. So important 3 aspects that we need to evaluate during the workup are whether the ovulation is normal or not, whether the tubes are patent or not, and whether the uterine cavity is okay for implantation or there is some problem. So ovulatory disorder comes under the most common factor for female infertility. Tubal uterine may be congenital or acquired, cervical factors, and even the lifestyle, like sedentary lifestyle, stressful working conditions, may be related to excessive physical activity, or even the psychological factors can suppress the HPO axis and results in anovulation. So WHO classification, they divided it into the 3 groups. Group 1 is basically hypo patients where the FSH and LH levels are low. There is defect in the secretion of either the GnRH or FSH and LH that ultimately results in anovulation. Group 2 belongs to, so 85% anovulatory infertility comes under group 2, and in group 2 90% is because of the PCOS anovulation. So you can estimate that PCOS is one of the important factor for female infertility. And group 3 is hypergonadotrophic hypogonadism, where the FSH and LH levels are high and basic problem is at the level of ovaries. Beside the ovarian factors, the other hormonal factors or hormonal causes that we need to evaluate are: one is the thyroid dysfunction and second is the prolactin. So our routine endocrine workup or hormonal panel includes FSH, LH, estrogen for the ovarian function evaluation, TSH and prolactin. So these 5 hormones are usually prescribed in our workup. The recent classification by FIGO, ovulatory disorder classification in 2023, is hypo-P classification. So type 1 is hypothalamic causes, type 2 pituitary causes, type 3 ovarian, and because PCOS is the most important cause of anovulation, so they make a separate category, type 4 for the PCOS. So in ovulatory dysfunctions, the patients usually present with the complaint of, what are the common complaints? Anovulation usually presents as delayed cycles or secondary amenorrhea. Sometimes polymenorrhea is there, but usually these patients came with the complaint of delayed cycles. And if it is associated with the hyperandrogenic picture, then the diagnosis is almost confirmed as PCOS because 2 out of 3 criteria of Rotterdam are fulfilled. If the patient presents with the complaint of headache, some changes in vision and milk or watery discharge from the breast, then the first thing that need to rule out is hyperprolactinemia. In thyroid disorders, again, hypothyroidism is more common and it usually presents as weight gain, lethargy, constipation, hair fall. So these are the common complaints if the patient is having hypothyroid anovulation. Also, we need to ask about the mental and physical stress. And in type 3 category, that is hypergonadotrophic hypogonadism, we have to find out the symptoms of premature menopause. Examination again depends on history. What provisional diagnosis you make with the history further help in the examination. So if we are suspecting PCOS, then we have to check for the BMI, central obesity, signs of hyperandrogenism and sonography for PCOS morphology. Similarly, if we are suspecting hyperprolactinemia, we need to check out the breast for any milk or watery discharge. Same for hypothyroidism, if there is any goiter, weight. For Turner's, you all know the signs of Turner's syndrome: overweight, underweight, excessive physical activity, obesity, presence or absence of secondary sexual characteristics if we are suspecting the hypogonadotrophic hypogonadism. Similarly, if we are suspecting hypergonadotrophic, again the symptoms of premature menopause can be there, like hot flushes or small uterus. So we have different tests to confirm ovulation, but the most important one are the follicular monitoring by the transvaginal sonography, or if patient presents in the luteal phase, then we check the serum progesterone level and it should be more than 3 nanogram per ml. Other tests like basal body BBT that you should know from examination point of view. Urine LH surge kits are there. If the kit shows double line, means LH surge, then the ovulation is imminent in next 24 hours. Cervical mucus test is almost obsolete and endometrial biopsy is an invasive or operative procedure, so usually we avoid. What are the most important ovarian reserve test? Out of these three, which one is the most important and the most commonly used? AMH levels. So anti-Mullerian hormone is the investigation that we use to assess the ovarian reserve. It should be more than 1 to 3.5 is the range, and less than 1 suggests the diminished ovarian reserve, but we have to correlate it with the transvaginal enteric follicle count. So enteric follicle count is equally good test to assess the ovarian reserve. And FSH and estradiol levels, sometimes we use FSH if it is more than 15 and E2 if it is more than 80. It suggests the poor ovarian reserve. Now come to the tubal factors. What are the most common causes of tubal infertility in India and foreign countries? In India, the most common tubal factor cause of tubal infertility is still tuberculosis. So tubercular inflammatory disease, tubercular PID is almost equal incidence in India as of STIs. So in Indian patients, one of the important things that we need to rule out in tubal blockage is genital tuberculosis. Then sexually transmitted infections like gonorrhea and chlamydia. These two are the most important causes of STDs and tubal factor infertility, and post-sterilization sometimes. How do we evaluate tubal factors? First, when we suspect the tubal factor infertility, if there is history of PID like excessive white discharge, pain lower abdomen, history of ectopic pregnancies, and in tuberculosis, what is the most common complaint? Hypomenorrhea, decreased menstrual flow is the only complaint with infertility, is the only complaint that the patient come with in OPD, and that clicks towards genital tuberculosis. Now the common tests that we do are hysterolaparoscopy is the gold standard, no doubt, but sometimes if everything is within normal limits like hormonal workup, like transvaginal sonography, like history, if everything is within normal limit and suppose the history is suggestive of PCOS, we confirm it by the sonography, then there is no need to go for hysterolaparoscopy. We can evaluate the tubal status by HSG or SIS, saline infusion sonography. So HSG and sonographic evaluation both are equally good for the tubal evaluation. What is HSG? We inject a dye through Lesch-Wilkinson cannula through the cervix and take the X-ray images of uterus and tubes. So these are the laparoscopic images. You can see the uterus and bilateral tubes with the dye test, chronoperturbation, CPT positive on both sides. In second picture, you can see a dilated lateral half of the tube termed as hydrosalpinx, maybe PID, or maybe you can see some small tubercles. It could be tubercular also. HSG images, we can see the uterine cavity, the contour of the uterine cavity, bilateral tubes, and patency of the tubes. So we can rule out congenital malformations as well as tubal patency. Similarly, what is hycosis? In hycosis we use a dye other than iodine based dye that we use in the HSG. So these are ecogenic dyes, commonly came with the name of EcoVist, that we inject in the uterine cavity and then take the X-ray images. So the tubes can be delineated as the ecogenic tubular structure. So SSG is a good investigation because it can be done as outpatient sonography room. It uses saline, not a dye. It is less painful and it is less costly also, but the only disadvantage is that the assessment is not as good as it is in the HSG. And in HSG we got a film also. So we got an evidence of tubal patency that can be produced for further consultation. Last benches. So uterine cases could be congenital or acquired. Congenital usually septate, biconjugate, uniconjugate uterus. In acquired deformities, it could be fibroid, polyp or intrauterine adhesions. Most common cause of adhesion again is genital tuberculosis or PID. This classification you should know. History in uterine factors, they present usually with the recurrent abortions or some problem with the menstrual flow, usually hypomenorrhea, or it could be heavy in cases of fibroid or adenomyosis. Diagnostic test, transvaginal sonography is the commonly used investigation for the evaluation of uterine cavity or uterus, and its predictability is up to 96%. So it is a good 3D sonography is almost equivalent to hysteroscopy. So we also termed it as virtual hysteroscopy if we do 3D sonography. So these are the images that we get in 3D sonography. You can see the B1 is the uniconjugate uterus, D is a biconjugate, E is the septum, uterine septum. Again, different septums, F, G, H is the arcuate uterus and I is the T-shaped uterus with irregular margins. Again, genital tuberculosis. Hysteroscopy, you can see a band inside the cavity, septum. Cervical causes are less common, but still chronic cervicitis or cervical erosions are important causes of infertility as well as recurrent pregnancy losses. Recurrent early. Last two, all you. आधे जने आगे आ जाओ. Last row, girls. Or you can leave. I have taken your attendance. Last 6 girls. Chronic cervicitis and chronic cervical erosions are again a very important cause of infertility. So local examination that we do by per speculum or per vaginal examination is very important in the workup of infertile females. So Fern test, postcoital test, usually we don't do in our OPD practice, but a good per speculum examination is very important to rule out the cervical causes of infertility. 5th row. Now come to the male factor infertility. So roughly 40 to 50 means half of the infertility belongs to male. So in male factors, the important that classification that we do is pre-testicular, testicular and post-testicular causes of infertility. Pre-testicular basically related to the hypothalamic pituitary axis or some systemic disorders like hypothyroidism, hyperprolactinemia or some sexual dysfunctions. Testicular Basically, the primary testicular dysfunction or testicular failure, and post-testicular are basically obstruction at the level of vas deferens or ejaculatory duct. So pre-testicular, testicular and post-testicular. Now comes the history. So a good history is very important in male infertility, history of any sexual dysfunction, any past history of mumps, orchitis, STDs again gives an indication of obstructive pathology. Any surgical history, again the chances of obstruction are high. Then any use of any drug, the pre-testicular suppression of hypothalamic pituitary axis can happen with the anabolic steroids. Occupational exposure to the high heat, radiations or heavy metals again affects the spermatogenesis, and excessive use of smoking, alcohol or occupational exposure to some chemical again can result in the defective spermatogenesis. Now come to the physical examination. So in male patients, to rule out pre-testicular causes, that is hypo, we need to go for height, weight and development of secondary sexual characteristics. If it is abnormal or delayed, then it gives idea about the hypo factor. Local examination to rule out testicular causes of infertility or post-testicular obstructions. So in that, a testis, epididymal, vas deferens, ejaculatory duct we can't palpate, but if we are suspecting some ejaculatory duct obstruction, then transrectal sonography is the investigation that we prefer. Varicocele grading you should know 1, 2 and 3. So in male partner we need to do a single investigation, that is semen analysis, but it should be done, we should give a proper instruction before going for the semen analysis. How much the abstinence should be? 3 to 7 days. How to produce sterile sample collection, and a proper investigation, proper lab criteria should be followed while doing the semen examination. Then if we are suspecting some obstruction, then we advise for the Doppler studies or transrectal sonography. If we are suspecting hypo or hyper, again we go for the hormonal evaluation, FSH, LH, testosterone, prolactin and TSH, the same endocrine panel that we use in the female partner. If we are suspecting obstructive pathology, or to differentiate between the obstructive and non-obstructive cause of azoospermia, we need to go for testicular biopsy and histopathological examination, and chromosomal or immunological analysis sometimes if we are suspecting in that way. WHO semen analysis you should all know for the viva purpose. How much should be the volume, the sperm concentration, the total count, the motility, everything is important. Oligo is the low sperm count, astheno is the poor motility, terato is the abnormal morphology. So we called it as OATS, oligo, astheno, teratozoospermia. Azo is absence and aspermia is absence of ejaculation. Azo could be obstructive or non-obstructive. So we differentiate it by the FSH levels. In obstructive it is normal. In non-obstructive it would be high because of the absent spermatogenesis. Seminal fructose test is again an important enzyme that we check for the obstructive pathology, or rather to check the level of obstruction. If it is below the seminal vesicle, then semen fructose will be present or absent. semen fructose absent, it means obstruction is below the level of seminal vesicle because it comes from the seminal vesicle. Genetic causes, important one is the Klinefelter syndrome, presents with the hypo, Y chromosome microdeletions and the CFTR gene mutation. These are the three genetic tests that we do if we are suspecting some genetic cause of male infertility. Same hypo, hyper, and normogonadotrophic. So, we used to do the workup of both the partners side by side by taking a good history, then examination, and then for the investigative workup. Same in female partner, the extra part that we need to cover is the menstrual history, the obstetric history, history of any contraceptive use, and same past medical and surgical history. Similarly, in the male partner, secondary sexual character development, any medical or surgical history, use of any drugs, occupational exposure, lifestyle, everything is important. So, a good history taking is very important in cases of male infertility. So, after taking detailed history and physical examination, a single test that we do in male patient is the semen analysis. And if it is abnormal, then we go for the hormonal workup or sonography, Doppler studies. In female partner, after doing history and examination, the first investigation or the most important investigation is the transvaginal sonography that give a gross idea about the uterine cavity and ovulation. And for tubes, we either do HSG or hysterolaparoscopy. Then ovarian result test, and if needed, other hormonal workup. So management includes either ovarian stimulation with timed intercourse is the first line treatment in cases of anovulatory infertility. IUI is basically indicated in cases of mild to moderate male factor infertility, cervical, chronic cervicitis, erosions, or if we are suspecting anti-sperm antibodies, unexplained infertility, then the first line therapy is the intrauterine insemination, and IVF in cases of tubal factor infertility, stage 3 and 4 endometriosis, severe male factor infertility, and after failure of 2 to 3 cycles of IUI. So infertility definition, we start our workup after 12 months of regular unprotected intercourse. We evaluate both partners together by a good history and examination. In cases of male, semen analysis, and in cases of female, tests for ovulation, ovarian reserve, tubal patency, and hysterolaparoscopy if indicated. Early referral is needed if the female age is more than 35, azoospermia, or if there is known cause of infertility. Like in cases of undescended testes, we start our workup immediately. So emotional support and realistic expectations improve outcome in cases of infertility. Thank you.